Good morning to professors, consultants, and my fellow colleagues. I'm Ho, first year trainee from Hospital Pulau Pinang. I'm going to present my research with the title of Roles and Outcomes of Surgeries in Large Anterior Mediastinal Mass. So large anterior mediastinal mass encompass a wide diversity of neoplasms which offer diagnostic and therapeutic challenges. The anatomical complexity of these large mediastinal tumors, often with compressions, obstructions, or invasions of surrounding structures, imposes clinical challenges in terms of surgical feasibility, tumor resectabilities, and disease curabilities. These patients, they often remain asymptomatic until compression symptoms occur, usually characterized by respiratory and hemodynamic decompensations due to mechanical compressions of mediastinal structures, what we call a mediastinal mass syndromes. Due to the rarity of this clinical entity, very few literature has been done on these large mediastinal masses. Therefore, in this series, we aim to describe the diagnosis, surgical feasibilities and approach, as well as the outcomes of surgery in large mediastinal masses. So it's a retrospective analysis conducted in our centers from 2018 to 2020. We include patients who are more than 18 years old, patients with anterior mediastinal mass more than 6 cm, measured at the maximum diameter on C3 thorax, who underwent surgical biopsy or surgical resections. We exclude patients more than 65 years old, patients with large mediastinal mass but did not undergo any surgical interventions, and of course, patients with poor functional status, such as those with ECOG 4 or 5. So if you look at the results, total of 78 patients were referred for anterior mediastinal mass, but only half of them have mediastinal mass more than 6 cm. The average age was only 36.4 years, with predominantly female. So the rest of the result, I'll be presenting the following slides. So looking at the flowchart of our series, all of 42 patients with large mediastinal mass, 22 of them underwent surgical biopsy, in which lymphoma was found in 16 of them and was referred for definitive chemotherapy. So the remaining 6 of them were found to have germ cell tumor, and 2 of them were resectable and underwent surgical resections. 4 of them were deemed unresectable at the time of diagnosis, and we referred them for neoadjuvant chemotherapies. So at the end of chemotherapy, 2 were resectable and subsequently underwent resections, whereas the other 2 of them were still unresectable and we had to refer them for palliative chemotherapies. The remaining 20 patients who were referred for surgical resections underwent complete resection subsequently. Look at the baseline and preoperative demographic characteristics. About 1/3 of them do not have any comorbidities, 14% of them have hypertension, 6 of them have myasthenia gravis, 2 of them have COAD, 1 have ischemic heart disease, and 1 have history of strokes. So majority of patients have symptoms at the time of reference, with most of them having cough, and a number of them have mediastinal mass syndrome, with 4% complaint of dysphagia, 7% with SVC syndromes, and 7% complaint of orthopnea. There were only 9% of patients who were asymptomatic at the time of reference. Now, if you look at the average tumor size in patients with mediastinal mass syndrome and without mediastinal mass syndromes, the average tumor size in patients with mediastinal mass syndrome is significantly bigger than those without, which is about 16.8 cm. And in patients without mediastinal mass syndrome, the average size was only 11 cm. So most patients underwent elective surgery, and of all patients that underwent surgical biopsy, about half of them were done through the WETS approach, 7 of them were done through Chamberlain procedures, and 3 of them were done through thoracotomy approach. And of all patients that underwent surgical resections, about 70% of them were done through stenotomy, and the remainings are thoracotomy and hemicranial approach. So if you look at the surgical diagnosis of tumor, most of them have lymphoma, followed by thymoma and germ cell tumor. So what about the outcomes of surgeries? More than half of the patients required ICU admissions, and the remaining patients were extubated at the end of surgeries, and these patients were the ones that underwent surgical biopsy. The average length of hospital stays was only 6.4 days, and none of the patients require cardiopulmonary bypass support. Our center does provide cardiopulmonary bypass standby in cases where you have a huge mediastinal mass with evidence of local invasions to the vascular structures or even pericardiums. So in terms of complications, we have 3 patients with prolonged alex, we have 1 patient with unilateral cranial nerve injury, and 3 patients with superficial wound infection. But all these patients were discharged well subsequently. We did not have any immediate post-operative mortalities, but we did have 1 patient who succumbed at the day of 48 after surgery due to severe sepsis. So what do we need to discuss before performing surgery on this large anterior mediastinal mass? So in terms of preoperative preparations, we had to study the anatomical assessment of the mediastinum. So CT thorax remains the initial choice of imaging modalities. And of course, MRI is very useful in soft tissue differentiation and delineating the tissue boundaries, such as you want to look at any invasion to the mediastinum or any invasion to the chest wall. And vascular assessment of the mediastinum is very important. It's to identify any invasion to mediastinal vascular structures and, if possible, to identify the feeding vessels. Because embolization of this feeding vessel can be done in this large tumor if possible. So what about the preoperatively tissue diagnosis? Usually done through FNA or core needle biopsy by imaging guidance or guidance by endobronchial and transesophageal ultrasounds. The 2014 NCCN guidelines on thymic malignancy actually advise against biopsy if a resectable thymoma is strongly suspected based on clinical and radiological features due to the fear of disseminations. However, biopsy may still be indicated when there's suspicion of lymphoma or unresectable disease by CT scan, because we need to obtain the tissue biopsy prior to referral for subsequent chemotherapy. So what is the role of neoadjuvant chemotherapy in large anterior mediastinal mass? Of course, it's very useful in reducing tumor volume and extent of invasion in cases where you have a large mediastinal mass and not suitable for primary resections. And in thymoma, neoadjuvant chemotherapy is very useful in achieving volume reductions. So in our series, none of the patients were actually referred for neoadjuvant chemotherapy in those with thymoma because all were deemed resectable at the time of referrals. And of course, we want to avoid delay in curative surgeries. So in large thymoma, neoadjuvant chemotherapy is able to improve complete resection rate and improve overall and recurrent-free survival. So benign mature teratoma do not respond to chemotherapy. So all patients in our series with mature teratoma were scheduled for early operation as soon as possible since they were all symptomatic. For mediastinal non-seminimatous stem cell tumor, treatment of choice is usually neoadjuvant chemotherapy followed by surgical resection of residual tissues. So similarly, in our cohort, 2 patients underwent surgical resections upon completion of chemotherapy. So regarding the surgical approach, midline sternotomy is still the approach of choice in our center for large anterior mediastinal mass. The midline approach was extended to hemiclancure in 3 patients for complete resections. So what have become increasingly popular, but still not adopted in our centers due to certain concerns, and most importantly, concern of achieving complete oncology clearance, and it's a confined mediastinal cavity, and it contains a lot of wider structures. In conclusion, published data on surgery in large anterior mediastinal masses remains limited, and this series has shown the clinical feasibility of definitive surgery for large mediastinal mass with positive outcomes. So given the rarity of mediastinal mass in clinical practice, the detailed pre-op preparations with multimodal imaging and MDT discussions is very essential for favorable surgical outcomes. So these are the references. That's all for now. Thank you very much.